webinar session. Today we're going to be talking about maximizing patient estimates to increase point of service collections. We'll give everyone a couple minutes to kind of get settled in and signed on here. I can still see some people trickling in here right as we hit 2 o'clock Eastern. My name is Brad Josephson. I will be moderating today's session for PMMC, and we're really going to be talking about, from an educational and best practice standpoint, how to improve your collections by looking for specific goals and opportunities for your individual facility, and really honing in on how you can integrate patient communication strategies to really encourage and facilitate that upfront payment. We realize that some folks on today's call probably have a patient estimate system in place, but might not be leveraging it to the best ability. So we're going to hopefully give you some takeaways and steps that you can implement into your patient estimate process and collections process to really fully take advantage of those patient estimates. Before we really get started, I'd like to just cover a couple of housekeeping items. On these webinar sessions, we like to be as interactive as possible. So our speaker is going to be asking a couple poll questions, and he will give you a heads up when he starts running those. So if you would respond to those poll questions, it gives us a better idea of the audience and kind of where everyone stands in this whole kind of area. And then also, we will be taking questions at the end of the webinar, and you will see a questions panel within your GoToMeeting dashboard. So you can simply type in a question, and I'll be keeping an eye out for those, and we can pass them on to our guest speaker, who I'll introduce here in just a minute. I'll give you a quick introduction of PMMC. Some of you might be familiar with us. For those who are not, we are a revenue cycle management firm based out of Charlotte, North Carolina. We've been peer-reviewed by HFMA, and we were recently ranked number 7 on Modern Healthcare's top revenue cycle firms in the country. We work with about 400 hospital clients, and our main goal is to help drive financial performance and improve bottom line. And one of those areas is improving patient collections, where our guest speaker today, Collin Quinn, really specializes in. So with that, I'm going to go ahead and turn it over to Collin.
Thank you, Brad. Appreciate the intro. Good afternoon, everyone. My name is Collin Quinn. I've actually been with PMMC actually coming up on 5 years now. Started back in 2010 as a member of our Estimator Pro Services team, where I served as a senior implementation manager for several years. And I've recently sort of transitioned over the past year into our Director of Systems Integration. However, I still work very closely with our ePro Services department as it relates to new and existing client installs and working with workflow initiatives and reporting services. So, so I've done a lot of implementations with our particular estimator tool, and done a lot of work, just helping organizations kind of look at their existing workflow and then making, their estimate process work for them. So, just a brief agenda for today's meeting or for today's presentation. Kind of start off with today's realities. Then we're going to look at sort of establishing or setting your estimate and collection goals. We can kind of look at that at a very high level as sort of an industry standard, all the way down to facility-specific goals. We'll then transition over to sort of the patient estimate process workflow, kind of what we see typically when we go out and do these implementations, and looking at setting up those whatever work or estimate tool you utilize to make sure it best fits your existing sort of patient flow, if you will. We'll also look at some pre and point of service collection best practices, so we'll definitely target those. At the conclusion, we have a couple case studies that we'll share as far as success stories, and then of course we'll kind of wrap things up with some final takeaways, and then we'll also open it up for questions. So as Brad mentioned earlier, If you have a question as we go through, you can look in your GoToMeeting sort of panel there. You can log those questions. Brad will keep track of those, and we'll make sure we get those addressed today at the conclusion of the call. So before I get started, just to give you a little background on sort of how this presentation came about, this material was actually presented at an existing client of PMMC's back in July at their request, and they had been a client of ours since 2011 and had a lot of success as far as creating patient estimates. Things have been going quite well. But what they wanted to do, they actually were bought out by another sort of parent company, and they were trying to really maximize their estimates and target sort of an increase in collection. So we came on site and actually presented this material, and there was a great deal of success sort of following our site visit and sort of the introduction of some of these best practices and sort of suggested methods. And we thought that this was sort of a valuable add-on, if you will, and we thought that we would share this information to you. So typically we don't do sort of Estimator Pro consulting services, but again we felt there were some great takeaways from this presentation, so we felt this was worth sharing. So without any further ado, I mentioned we start off with today's reality. So we've got 4 bullet points here on this particular slide. Some of these may be a bit shocking. You'll see the first one: 54% of patients stated they are confused by their healthcare bills. This was all based on a TransUnion healthcare report generated in fourth quarter last year. They surveyed just over 7,400 patients, and so 54%, so over half, stated they were confused by their healthcare bills. I was a little surprised it wasn't more. Maybe some of these patients weren't being completely honest. Only 25% of patients are offered cost estimates, another number which I thought was actually low. I was expecting to see more of that. So I believe back in 2012 or maybe it was 2011, I think that was at 18%. So it's grown, but just slightly. The third bullet point: 62% of patients are surprised by their out-of-pocket costs. That number didn't surprise me. The last one: 80% of patients think that estimates are helpful. So despite the fact that there might be sort of some sticker shock when that estimate or a quote is first presented to a patient, 80% do find that information helpful. So you'll see later on in the presentation that we've done some sort of corollaries to patient satisfaction scores. So a lot of times, with new implementations, when people put in an estimator tool, again, there's some shock at first, but if things are communicated properly, and that's another thing we'll focus on today, both sort of internal communications with your organization and external communications with your patients. But we do see that with a lot of those estimator implementations, patient satisfaction scores do significantly go up. So in fact, one of our case studies alludes to that. So we'll get to that a little bit further in the presentation. Again, rising deductibles, another reality of today. You can see that with this slide, the average deductible back in 2009 was about $826. That grew, it has grown steadily over the past 5 years. You can see here the last number here taken was in 2014, roughly just over $1,200. So that's around $80 per year in that 5-year time frame. And I'm sure in 2015 that's probably grown, I would say, maybe to $1,250. Of course, small firms are probably seeing the highest, you can see that with the graph, are probably seeing the highest jumps, if you will, with the deductibles. But again, it is an overall trend. You can see that for all firms. So no shock there. To go along with that, I was reading an article last week that they're actually, high deductibles are actually more common now in exchanges than employer plans. So one of the stats that I took away from that was roughly half of all workers in employer plans have an annual deductible of at least $1,000. And the average deductible, get this, has grown at almost 7 times faster than wages. So we kind of keep that in mind for perspective. Especially true for those with ACA coverage. About 43% of the enrollees had deductibles of $1,000 or more, compared with 34% of employees with health insurance. So that was interesting to me to actually read that. So, of course, with the Affordable Care Act, with the introduction of these exchange plans, obviously deductibles are rising just overall as a result of the introduction of those plans. So again, a trend that we've sort of seen. I think a lot of people were expecting that, but it continues. Which really, this leads us to our next sort of talking point here, which is price transparency. I'll let you read through this, but basically, you know, the bottom line down at the very bottom, the time for price transparency in healthcare is now. Patients are doing their due diligence. They're doing their research. Basically, those providers that have higher costs are really going to have to prove their value. There's no getting around that. Just to reference a couple of their sort of statistics that I saw, this was based on a TransUnion report, but about 1/3 of patients currently receive some degree of pricing information. But out of those that were surveyed, 80% of respondents said they valued the price transparency on par with bedside manner when they were choosing a provider. In fact, 51% even said they would change their healthcare providers to receive more pricing transparency. So I think that's very, very telling. So we'll speak to that, of course, and you know, with that's where these estimates and the accuracy of estimates really comes into play. Okay. Obviously, the environment today is changing, and the focus really now is collecting, you know, the collection of money at the point of service or prior to the point of service. So obviously, insurance companies are requiring policyholders to take on more financial responsibility for their health care benefits. Of course, I've seen that. Self-pay balances within healthcare organizations are increasing. Of course, that's a direct result of higher deductibles, some co-insurance percentages going up, higher co-pays, etc. And with that, the resolution of those self-pay account balances are taking longer for healthcare organizations to sort through. Obviously, there are a lot of groups that have sort of taken on charity care or have determined, you know, parameters for you know, establishing some sort of charity care and subsequent collections. So because of that, again, it's taking longer. You know, once that patient has that service, if the collection isn't obtained up front, any sort of patient responsibility obviously becomes much more difficult to collect as time goes on. So and we'll actually go into a little bit more detail on that fact on the upcoming slide. Healthcare organizations are realizing that patient satisfaction increases as patients are informed of their financial responsibilities. Again, I'll point you to the case study at the end that we had with one of our clients who their satisfaction scores drastically went up just within the first several months of the introduction of an estimate. So, so we are seeing more and more groups that are looking at these opportunities to increase their satisfaction scores by offering some of that pricing transparency through sort of a quote or a price estimate, if you will. The collection advantage, I just referenced that obviously it becomes a little bit more difficult to collect for after the point of service. So this slide and this graph in particular show your collection probability, and you can see the pretty drastic decline ranging from prior to service. So if it's a pre-registered event or pre-scheduled, for those people that, you know, where there's a patient responsibility that's determined in advance, obviously it's a lot easier to collect that up front as opposed to after you know, the service is performed, the patient's left the facility, and then you're basically you know, relying solely on just, you know, a series of bills that are going out. So so you can see the drop off here. You really want to take advantage of that point of service or prior to the point of service as far as collections go. You know, obviously the numbers don't lie, so the chances of collections, they're much, much higher. Okay. Now, confronting patient responsibility. We've got a couple of cartoons here. Obviously, it's tough, and really the bottom line is no one likes financial surprises. Obviously, when a patient goes to a hospital, there are really two questions: am I going to be okay, and how much is this going to cost? So we can't always answer the first question, but we can answer the second, or at least give a rough estimate. So it's our belief that customers should know what their anticipated responsibility is prior to the service to reduce collection issues, and also to address and sort of preempt any patient dissatisfaction concerns prior to receiving a bill. Okay. So now we're going to talk about sort of facility-specific goals. Okay. So the first question a lot of times I like to ask is, where have you struggled previously? If you already are creating estimates, where have you struggled? And then on top of that, or aside from that, you can look to establish some sort of goals for the future. As far as estimates go, deciding on an overall estimate creation percentage of your total registration. So out of, let's say, 1,500 registrations, what percentage would you expect to create an estimate for? Percentage targets by patient type. Of course, we see much higher volume, of course, with outpatient estimates, but we do have several clients that are really targeted inpatient encounters as well. And really, like I said, this is going to be facility specific. You want to sort of establish those target percentages based on patient type. So of course, you may have maybe a goal of 80% for outpatient, and maybe 20 to 30% for inpatient. ER is always a difficult place to incorporate estimates as well, but even setting some sort of goal in the ER too is beneficial. So the last part of that is the time frame for estimate creation. Do you anticipate these estimates being created, again, prior to the point of service, at the point of service, maybe as a patient walks in for just a walk-in ambulatory visit? Or perhaps there's a more elaborate process that starts prior to and then actually wraps up where the estimate's presented at bedside. So, but it's good to have, again, those time frames, and maybe that has some variation depending on the patient type as well. So you may have different processes, but again, going back to creating at least a goal for those particular types or the type of registration, that's a good starting point. The next part is collection goals. So, do you have a pre-service collection goal or an annual collection goal? And then establishing a collection goal as a percentage of overall patient responsibility. So, out of those estimates that you create, you look at that total patient balance. What do you anticipate, or what would you like to collect? What percentage of that total balance would you like to collect? So, putting those numbers down and actually establishing a goal when you're going to implement an estimator tool is a must, I think. Pre-service collection goal is a percentage of missed opportunity. We'll actually talk a little bit more in detail about tracking some of those missed opportunities a little bit later in the presentation, but that is an important part as far as sort of determining where you would expect estimates to be created, and then being able to track those as the registrations take place, as patients are discharged, and then looking again where collections were made and where they were possibly missed. The time frame for pre-service collections, again, going kind of back to the whole estimate creation process, but there's also a time frame for the collection part as well. So determining what actually constitutes a pre-service collection. Is it within 10 days of service? Is it within 5 days? Maybe you've got some leniency on the back side of that as well. So I also noted there are two variations by patient type. Perhaps, again, there's pre-service collections. That could vary depending on patient type as well. Maybe you have different criteria set. So those are things to look at, again, when you're really trying to establish or lay out goals for your project. Okay. Estimate creation criteria. Okay, so these are some things we want to look at as far as determining when estimates should be created. First, which departments? Outside of that, what patient types? When patients are scheduled, when they're pre-registered, when they're pre-admitted at the point of service? Are there certain procedures that you want to target or perhaps stay away from? And then also looking at your insured and your uninsured population and focusing on particular payers. So going back to the very first bullet point, which departments? We see a lot of opportunity, of course, with the pre-service, pre-registration, the registration groups, insurance verification or insurance verifiers, surgery scheduling, and again, just a lot of the front-end staff. So those are going to be your departments that you really want to maybe target. As far as patient types, if you're looking at inpatient, outpatient, ER, or if you're looking at some of those subtypes where it gets a little bit more specific. So again, if it's radiology, lab, wound care, anything like that, you can start looking at those. And again, when I talk a little bit more in more detail about the missed opportunity, like reporting and tracking, that's where those patient types really kind of come into play, because again, as you start to build your rules for, hey, we would expect estimates to be created for these particular types or subtypes, it makes it a little bit easier to track too, just for trends. So when patients are scheduled, pre-registered, pre-admitted, point of service, this really depends on the facility. Depending on size, volume, etc. That's where that comes into play. That just has to be determined by the facility themselves. So again, if you're tying this to collections, obviously you're going to do better. Anything that's sort of pre-service or pre-registration, but that doesn't work for everyone. So I think identifying your best opportunities and then trying to build a plan around those opportunities, that's where you really want to focus on what's going to work for you. You don't want to set yourself up for failure. What procedures? I mentioned there's some procedures that maybe aren't worth creating estimates for. Maybe they're 95% of the time they're covered by a payer. So but maybe there's other procedures that are, have low reimbursement. You really want to make sure that you're collecting that whole patient responsibility. So maybe you want to target those. So that comes into play when you're really communicating this process to whatever staff's going to be performing these estimates. So, but yeah, again, just you want to look at and then see, are there certain procedures we want to really focus on, or are there certain procedures we want to steer away from? And again, the last bullet point here, insured and uninsured self-pay. Obviously you're going to target your commercial payers, but with the trend with the high deductibles, larger copays, you're obviously going to want to make sure that you are able to collect on those, but you don't want to forget about your self-pay patients as well. So maybe putting some sort of, if you don't already have one, a self-pay policy into effect, or making sure that your whatever estimator sort of tool or software that you're using allows you to build in software to accommodate your self-pay plan. So, but again, going back to this, with the estimate creation criteria, are you expecting to create estimates for all your commercial payers and self-pay? Are you going to maybe exclude your Medicaids, things like that? So again, we'll touch on that a little bit more when we go through the missed opportunity report criteria. Okay. POS collection opportunities. With this particular slide, if we were to look at a group that began collecting with just sort of the standard, if we're looking just at collecting copays, $25 to $250 patient copays, which would include some sort of minor sort of insurance verification, might be just a quick call to the payer, it might be looking at the back of an insurance card, perhaps using a clearinghouse website. That goes hand in hand with this third bullet point based on the limited protocol for determining deductibles. So again, if you're calling and getting that information, just loosely determining a rough, patient responsibility. Just starting with that can translate to anywhere between 0.1 to 2.5% of net cash collections. But that can lead to other opportunities, and that's exactly what this slide is showing. So you can see the typical POS amount and then your average total POS opportunity. So if we look at the next slide, depending on volume, you can see the outpatient visits there at the top. We have the commercial volume, total patient collection opportunities, and then copay only. You can see as the volume increases, what you stand to possibly collect. So over on the right, we have our POS goals. That ultimately comes out to about between 1.5 to 2% of net cash monthly collections. Many of you know that is an industry noted standard. So 2%, right around there, and/or your patient cash collection of roughly 25% to 40% of your total monthly patient responsibility. So, so you can see just even starting, just with targeting copays initially and then sort of moving on, there's a lot of opportunity there to really bolster your collections. Now, when we do implementations, we really look at sort of these. There's really 4 sort of different areas here noted here. The pre-registrations have the informational requests. So going back to the whole pricing transparency, I think many of you probably have price shoppers or those call-in inquiries. You know, how much is this going to cost? Many times those are for the uninsured, they're for self-pay, and then also now we're seeing a lot more of people that are a little more savvy as far as knowing their benefit information. They do have, you know, some sort of commercial coverage, and they just want to know. So we are seeing an increase in those. So again, if you're looking at implementing an estimator tool or application, you really want to be able to address these sort of 3 to 4 scenarios. So again, handling those pre-registrations, the pre-admits, on up through registration, where a lot of times, you know, the estimate's actually created in advance of the service. The time of service or your walk-ins, where you know, the admission staff are trained to where they basically, you know, they can take the patient as they present. They know what procedure is being performed, and they can, you know, relatively quickly turn around and provide a quote, you know, to that patient right there prior to the point of service or right at the point of service. And then again, the informational request, being able to handle those call-in inquiries where, again, somebody's just calling in and saying, hey, I have Blue Cross Blue Shield, I'm thinking about having this procedure done, can you tell me what this is going to run out of pocket? Or, you know, consequently, I don't have coverage, I'm shopping around, I want to know, you know, roughly I need to have this procedure performed, what's that going to cost? In which case you could, you know, present your whatever your self-pay offerings are. Okay. Cartoon humor here as it relates to collection best practices. Now, moving on to the estimate creation process. We're going to talk a little bit about best practices here. Before we do that, though, I do want to do our first poll question. So let me.
And Colin, if you're having trouble with it, I can run it from my end too, if
you'd
like.
Okay, yeah, if you wouldn't mind. Yeah, this first one, we really wanted to poll the group to see how many of you today are actually generating or providing estimates. So, Fred, yeah, if you can trigger that.
And Colin, are you able to see the results coming in?
I've just seen the poll in progress.
Okay. Well, I can share the results. I can see them coming in from my end.
Okay.
Looks like about 70% of the audience has participated. So we'll give it another couple seconds here.
Okay.
If everybody wouldn't mind selecting an answer here. And we've got about 80% results in, so that's a good sample size. So it looks like about exactly half the audience does have a patient estimate system in place today. 23% say they do not, and then 27% say no, but they are planning to implement one in the next year.
Okay, excellent, excellent. All right, well, thank you everybody for sharing that feedback. There we go. Okay. Got ahead of myself. So my first question for those of you that are currently providing estimates, are those being signed and scanned and included in either the patient's record or their financial records? The reason I ask that, and the reason I think that's important, it's for reference. You know, are you able to retrieve that information readily, especially if you have the patient signing off on those estimate forms? There have been a lot of studies that show that, again, when a patient's presented financial document, once that signature is on the document, it's sort of it really plays kind of in the back of your mind. It makes you feel more like you really are responsible for those terms. So, so again, if you are having patients sign those quotes or those estimates, it's good to have those either scanned or even just a hard copy placed, somewhere either in their financial record or the patient's medical record even. So maybe just in the financial section. So is there consistency across departments with the estimate creation process? So best practice is, you want consistency. So it doesn't do much good unless you've, if you really have departments that you're trying to steer away from that really just should not use, an estimate tool, make that clear. But really, the groups that we see that have the best success have, effective communication go out to all the departments, and the expectation is there that not only are they creating the estimates, but also with that, they're, communicating the patient responsibility either prior to or at the time of service. So what you don't want is a patient coming in for one particular service, being presented with a quote, and then also asked for whatever their patient responsibility is, coming back 2 months later, maybe for a completely different procedure, different department, and either there's no estimate created or there's an estimate created, but then that piece isn't there as far as collections. So again, you want to make sure you're consistent so that, again, if you have those return patients, they know what to expect. It becomes kind of part of the protocol. So again, it's very beneficial to have that sense of consistency, across all your departments. The other part here, registrars and financial counselors, whoever's going to be communicating, with the patients as far as the responsibility goes, they need to be confident in the collection process. So that will be, that confidence can carry over from making sure that your estimates are accurate. It's hard to be confident when you feel like you're guessing. So again, that's a lot of groups they want to strive for accuracy. So so you want to present a very accurate estimate. Also, you want to make sure that your staff are well trained and well versed in sort of that collection scripting or their approach to asking for money. We've got a couple of slides coming up where we'll kind of go through sort of a role play, if you will. They also need to be confident in their the benefit response that they're getting, whether that's by way of clearinghouse, phone calls to payers, whatever means your staff are utilizing for determining benefits or eligibility returns. The staff needs to be confident in that, because obviously that plays a huge part, in the calculation process with your estimates. So, so just going back to some of these best practices, these are the things that we feel strongly about incorporating and just making sure that if you're not doing these things, we strongly suggest sort of incorporating these into your processes.
And Colin, if I can just jump in with a quick question on that previous
Sure.
slide. In your experience, which departments are most likely to be creating estimates, and which departments should be creating estimates?
Okay, I'll sort of answer that in two parts. The departments that are, I guess, most likely to be creating estimates are, again, going to be any of your sort of front-end staff. And again, this can vary by size, but that's going to be your pre-services groups, pre-registration, your registration staff, anybody really working sort of on the front end, but also for some of the larger groups that have maybe their own insurance benefit verification team. Sometimes those people are the ones that are actually creating the estimates, calling the patients and communicating those, and following up with the patient accordingly. So typically, again, we'll see those are the departments that actually create the estimates. Now, as far as departments where estimates are created, if we're looking more at like hospital service, we're going to see those created, obviously more in the outpatient setting. Radiology is probably one of the highest, lab, wound care, outpatient surgeries, and a lot of stuff with sort of the ambulatory clinics, where you've got people, just kind of walking in, having a service, and then leaving that same day. So, so again, your front-end staff are really going to be providing it, but it does depend on sort of the departmental type or patient type as far as volume goes too with estimates.
Okay, great, thanks.
Okay, a couple other things that we'll look at here related to best practices. Do patients have a prior balance? If so, if you're already communicating, an estimate for today, there's no time like the present to, incorporate those prior balances due. So you might as well try to, wrap in or incorporate that. Many estimate applications or tools do have that ability to sort of tack on a prior balance or incorporate a prior balance due. So, that way you're not just collecting what's due today, you're actually addressing that, any of those outstanding patient liabilities. So, financial counseling too, if your estimator tool has options to set up a payment plan, or even if you don't, is just making sure that you have some sort of arrangements that are available. If maybe a patient can't make a payment in full today, they want to look to set up some payment terms, building out sort of that payment financial counseling criteria, and then adhering to that, and then having your staff, of course, know, by particular instance, does this account fall into this category where we can extend financial counseling? So you want to make sure you're using those if those are options. So with a lot of the implementations we've done, we've also seen that there are problem areas where they try to roll out an estimator tool. Many times what I've seen, ER of course is one of the most difficult places. Some groups really just try to target at least just getting the copay. We've got a couple suggested solutions for ER. Physical therapy is tough as well. Wound care, sometimes it's that one can be iffy. We've had a couple groups that have had a lot of success there, but they really, a lot of times with wound care, you have to identify particular codes. So that kind of goes back to what I had talked about earlier with identifying certain procedures that you really want to target, and knowing roughly total services for those particular procedures. So as it relates to the ER and the PT, physical therapy departments, maybe the estimate solution you have allows for this, but you can always target the ER visit levels. So you've got your levels 1 through 5. Those are CPT codes 99281 through 99285. And then, of course, with physical therapy, maybe if you're just trying to provide sort of a general quote for if nothing else, your evaluation and re-evaluation codes are listed here. Those are the 97001 and 002. So again, it can be tough to implement this in certain departments, but even just having a starting point or a reference point for this particular departments can be helpful. So some estimator software also allows you to sort of assign search words or keywords that help you identify certain procedures. Those can be very, very helpful if you're trying to, again, like for wound care, give sort of common nomenclature descriptions to certain procedures that might not be easily identified in your application. So, so those are some other areas where this information might be helpful. Okay. The next thing we want to sort of shift over to is internal communications and setting expectations. So we'll go through and pull up a couple of these bullet points. What parties and departments should be involved? That's kind of question one. Who's been involved in prior discussions? So if you maybe had tried to implement something, who did you talk to initially? Sometimes just by going back and looking at, okay, well, we spoke with groups A, B, and C. We never really communicated this to D. You can go back and kind of figure out, where some of those gaps were, maybe where you didn't have as much success as you would have liked. So our suggestions would be starting off at the highest level, board of directors, making sure that everybody's sort of behind the project, everybody's aware of what's going on down through the nurses and the physicians. You want to make sure that they understand that the your front-end staff are going to be creating these estimates, collecting money, which is good for the organization, but it may in turn cause some delays as far as getting patients back. So they need to have that expectation and knowledge, just to know that don't try to rush your front-end staff, because they're effectively communicating patient responsibility and collecting. So we suggest these sort of forward groups, making sure at least these groups are included in your internal communication. Okay. of course, one of the biggest parts is patient communication. So we can look around and say, today, what communication are you providing to your patients? What's been proposed for the future? Do you have some other thoughts on maybe what you could change? We've got a little sign up that says, please pay here. I say the writing's on the wall, quite literally. As I go around to do sort of training and client implementations, I always look to see if there's signs up saying that copay is expected at the time of service, or patient responsibility will be collected. Anything just notifying the patients of that part of the process. That's huge. So our suggestions would be, of course, signage. So anything that's posted, in your kind of waiting areas or any of the front desk or points of entry. Patient pamphlets. That's a great place to put that in. Maybe you have public service announcements that you can that you share with local news. Maybe it's something that's on your website. Another easy way to communicate things like this is through scheduled appointment communications or reminders. Many times people are told, hey, if you're coming in for a procedure, don't bring anything with you, don't bring any valuables. That's understood, but the problem with that is, how is the person supposed to pay if they're told not to bring anything? So, so again, that's another big part of how this information is communicated. So, our conversations held at the time of scheduling and pre-registration regarding payment expectations. That's important too. So, your surgery schedulers should be, well versed in sort of your estimate process, and then also the collection part of that. So again, it's consistent. It's communicated right there prior to the service being performed in advance. It's all the way up through when the patient arrives. That way, when they get there, the expectation is that they owe something today, and they need to be prepared to pay that. So our recommendation is basically patients with a financial responsibility should be contacted 2 to 5 days in advance of their visit. And of course, as you determine patient responsibility, if it's a self-pay or maybe there's some initial concern about being able to pay, if you have a financial counseling group or somebody that helps with setting up a payment arrangement plan, you should definitely utilize those resources if possible. And Brad, did you want to go ahead and trigger that second poll question?
Yeah, let's go ahead and launch that one.
All right.
So this poll question is asking, do you actively communicate to patients to encourage collections at point of service? So are you doing the things that Collin really just kind of illustrated? We'll just like to get an idea of the audience right here. So we'll go ahead and launch that. So it looks like this group is doing pretty well in that area. It looks like the majority are at least doing something. So 40% responded yes, 40% responded somewhat. So they're probably doing a mix of some of the things you talked about, Collin, and then about 25% said no, they're not communicating at all.
Okay. Okay. It's like honest responses.
You you have to appreciate the honesty.
Yeah. Thank you. Definitely. All right. All right. Well, to follow that, obviously, once you're kind of rolling, if you will, with the estimate process and trying to target those collections, you obviously want to be able to monitor that. So that's what we're going to talk about now. You've heard me reference several times throughout the call sort of a quote-unquote missed opportunity report or some sort of tracking mechanism. What we've seen is it helps to have, again, some sort of report that you're kind of just at a high level is at least showing your volume, sort of your volume where you'd expect estimates to be created as sort of a subset of that, and then something that shows where you've actually created those estimates. So it allows you to kind of look across those three areas and determine some level of success, hopefully, as far as generating or creating those estimates. So that information can be tracked. It usually makes sense to do it based on a particular date of service. So, but you can track those numbers. You could do it daily, weekly, monthly, quarterly perhaps. So maybe, hopefully whatever sort of tracking mechanisms you have, if you can incorporate it like that, that at least allows you to look for trends. Probably monthly, I think, is probably the most telling, as far as looking at your total number of registrations for the month and the total number of estimates that you actually created. So, and then on top of that, having some sort of a detail report to supplement it. That allows you, that serves sort of a twofold manner. One, it allows you to look at the account detail and look for, any trends. Or are there certain patient types that maybe are getting missed? Maybe those should be excluded from the report. But it also allows you to recognize training opportunities for staff as well. So maybe you've got a registrar that, you see that they've actually registered 50 patients. They only created one estimate. It sounds like there might be some opportunity for retraining, with that particular individual. So that's kind of, I think the best way to sort of track this, the whole process once you've actually got your estimate, application sort of rolled out, and you've communicated, that you are going to start doing these upfront collections. So, and as far as sort of, increasing sort of or fostering competition, if you will, between your registration staff, it never hurts to offer up. Maybe you could do a bonus or to for a particular user or even a department with the highest percentage of collections, a gift card, maybe a pizza lunch for the department, something like that. But friendly competition always works well. So just a suggestion and something that we've seen a lot of clients that we've worked with in the past do. All right, I'm going to go through these. This is just some collection scripting that we actually presented to the facility back in July. And really, the whole premise of this scripting, this is what you'd want to go through with your registration staff, or there's some variation of this. This is, again, it's just a suggestion. But it's a very sort of PC approach to addressing collecting patient responsibility. So basically, you want to, obviously, if you're speaking with the patient on the phone, confirm it's a good time. Obviously, if they're there in front of you, they're there for a reason, but you can obviously go ahead and communicate this as well then. But so you want to, of course, make sure your staff are polite and to the point. So be prepared when they make those phone calls. So you can see down here in the sort of fourth paragraph, based on the information provided by your carrier, we've estimated your responsibility to be X, inclusive of some of that benefit information that's already been determined. So you want to have that information at hand when you contact the patient. Always, give them an opportunity to ask questions. I referenced earlier, too, incorporating prior balance due. Note any outstanding bad debt. Now, like I said, if you've got the patient on the phone, you might as well take the opportunity to communicate that. Try to collect, everything at once if possible. So this is just a suggestion for including the outstanding balance. And then one of the biggest things is not would you like to pay today, but you'll see this last sentence, how will you be taking care of this amount today? If you can word it so that you're not really giving an option, that's sort of I think really the best practice here is really don't present it as an option. Be flexible. You can see here, make sure you ensure that you offer all forms of payment, cash, credit card, check, EFT, electronic funds transfer. We obviously see that a lot with maybe payment arrangement plans. So that's the other part of this. Again, you want to be confident but yet flexible as far as trying to accommodate how the patient can pay and with whatever means. So you're going to obviously get more no responses, no, I can't pay today. So again, you want to walk through a couple of these different scenarios and kind of pose it as, I can't pay today, I don't have the money, I only get paid, once a month or twice a month. This falls between paydays. So you'll see coming up with this and just walking through it with your staff will be really helpful because, again, it just prepares them to sort of for what they're going to encounter, as they, try to make these collections either over the phone or, again, just there in person. So you can see here, again, the EFT form will work best for you as we can take the payment on the day you get paid. Would that work for you? So, and even here, I can't pay the whole amount at one time. Can we do it in payments? Again, going back to that whole point, be flexible. if they're offering to pay something, you want to try to work with whatever terms they're kind of providing. So. Okay. And then the yes response. So maybe the sun's shining, there was no line at Starbucks that morning, and you got that great parking spot right there at the front of the facility. The patient says, yes, I would like to pay with my credit card. Obviously, those are going to go a little bit more smoothly. Basically, you can just reference, okay, let me get your information, we'll post the payment. Of course, offer that you'll provide the quote, and you'll be providing that, and just thank them again. So again, just having some scripting like that really is helpful for your staff to kind of walk through those scenarios and just, again, be prepared on a daily basis for the kind of responses they may get, whether it be on the phone or they're in person, again, as patients, present there at the front desk. So now I mentioned at the start of this, we had a couple case studies, and I'll just kind of go through these quickly so we can open it up for questions here in a moment. This first one is Baptist Health System, large group down in Montgomery, Alabama that we partnered with. They already were using a kiosk system with roughly 95% patient usage. A lot of success there. That was actually, they used that in turn in a couple or incorporated benefit responses within that kiosk exchange, basically. But we partnered with them, and they brought in our estimator solution. And they were able to achieve record point-of-service collections in just their first month. And this was, we were still sort of ironing out details and sort of workflow, but it did not stop them from actually achieving their highest collections ever. So we can provide these case studies if you're interested in reading these. But that was one of sort of our most recent, I guess, success stories as far as implementing an estimator tool. Ohio Health, another client also that they went live in 2012, but you can see just down here in this sort of bottom balloon, their POS collections increased, almost a little bit over 6 million just in 2 years, and a lot of that was just after that first year when they rolled over in early 2012 and began using an estimator solution. So they consistently averaged about 9,000 to almost 10,000 estimates per month. So very high volume. They used a unique setup where each registrar was actually responsible for creating their own estimates. So there wasn't really a centralized team per se doing this. It was sort of on the individual, but they had a great success rate as far as creating those estimates. Murray Regional group in Tennessee. The next couple of slides show some of their success following the implementation of an estimator tool. You can see this first slide illustrates the point-of-service cash collections. You can see back in August of 2008, they were below $25,000. But when we kind of wrapped up this study, that was in February 2012, you can see they were around 200,000. So noteworthy difference, and you'll see the trend sort of going up with of course, some peaks, at the beginning of the calendar year, as sort of plans sort of start over, deductibles were reset. So you can see, some corresponding drops, but overall the trend was up. As a corollary, their customer service improvement is noted here in the second slide. So you can see, again, going back, this was I think July and September of 2009, up through January, March of 2012. You can see that just a real steady sort of climb after April and June of 2010. So they really saw the correlation. So not only did their cash collections increase, so did their customer service marks. Okay. And just sort of to wrap up today's presentation, when implementing an estimator tool, you want to generate and provide estimates for any and all applicable encounters. So again, that's up for you to decide, but you want to stress consistency. So once you've determined where you want to create those estimates, you want to, again, be consistent, and then also determine some sort of tracking mechanism to sort of monitor that. Exercise consistent patient-friendly collection efforts, kind of like that collection scripting that we covered, using the methodologies that we kind of went through there as far as presenting different options to patients that have some sort of patient responsibility. So remember to utilize collection resources. Maybe those are in your estimator software or elsewhere. So again, in prior balances, if you can incorporate those, that's always best. Financial counseling arrangements, if you've got staff or individuals that are sort of tasked with those payment arrangement plans, make sure you're using them. Intercollections, if your estimator application allows you to do that, obviously you want to see ROI on whatever you've implemented. So make sure that you're actually entering collections so that can be tracked within your tool. And the use of the collection scripting, the electronic funds transfer, whatever documents you might have to help facilitate payment, time payment arrangement agreements, things like that. Just make sure that you're utilizing all your resources. Be aware that estimate and collection efforts are being monitored. That's really what you want to stress to your staff. Anything worth doing is worth doing right, and it's also worth being measured. So they should know that somebody in management is always going to be kind of looking behind them to make sure that they're creating estimates where they should. And, there aren't lapses based on payers or patient types and whatnot. Utilize some sort of missed opportunity report or reporting, along with maybe supplemental collection reports. So again, as long as that information or collections are entered into your estimate tool, you can sort of, a lot of applications will let you sort of run queries, or you can use the sort of standard reports, and you can compare those collection reports along with anything you're using to track those missed opportunities, to look for areas of improvement or departments or staff that you want to follow up with. And overall, providing accurate estimates keeps your community informed, which it does, increases patient satisfaction scores, which we've talked about, and it also facilitates timely pre-service and point-of-service collections. So again, if everything's effectively communicated both internally and externally to the patients, you really should see your pre-service and your point-of-service collections benefit as a result of that. And here's my contact information. So just as a follow-up to today's presentation, if you have questions, anything that we can't answer here in these last couple of minutes, that's my direct dial and my email address. So Brad, at this point, I think I will turn it back over to you, and we'll go through any questions that might have come through during the course of the presentation.
Thanks so much, Collin. I know you covered a lot here in the last 55 minutes, and with the last couple minutes here, I would like to give the attendees an opportunity to ask any questions, any clarification, or maybe anything that you weren't able to get to. So there is a questions tab in your GoToWebinar dashboard, and you can simply type in a question there, and I should be able to receive it and pass it over to you, Collin. I did have a question about the slides. We will be providing a copy of the slides as well as a recording of the presentation after today's call. So everybody on today's call will receive a copy of those. So we'll see if we have any questions coming in here. Looks like we do have one for you, Collin. Pull it up here. Well, I actually have one, Collin.
Yeah, sure.
You mentioned the importance of internal communication. Is there an area where we see communication breakdowns, and how do you recommend overcoming those within departments?
Yes, yes, definitely with internal communications. I have encountered quite a few facilities that have run into issues. I think the place where I most often see miscommunication is just starting again, going back to not communicating things to the physicians, the nurses, the ancillary staff. Basically, what happens, what we see frequently is, of course, the front-end staff or the registrars, they're doing their part as they were told and trained. They know how to use whatever processes or applications they're using to provide these quotes or estimates, and then obviously collect. But the nurses and physicians know nothing about it, or nothing was shared with them. So it really starts back in the core planning stages, where things weren't communicated to all the appropriate departments. And that's why on that slide, when I had our sort of suggested groups to communicate to, You really want to start even, like I said, at the board of directors. A lot of times there's physicians on the board, so there's the trickle-down effect, and so that's really how that can be sort of avoided as a problem area. It's just making sure that kind of communication starts at the top. All the parties know what's going on, so that way, if there are any delays or sort of holdups as far as the patient sort of workflow when you start up that whole estimate creation process, they're aware of what's causing the holdup and realize at the end of the day that, hey, that's okay. We're providing, our customer service is going to go up because we're providing these estimates, and then consequently, we're going to be bringing more money in because we're actually collecting up front as well.
Okay, great. I think we've got time for one more. Had a question about how much a hospital should expect to collect per patient when they're actually using patient estimates. Do you have any insight or numbers into that?
Yeah, I do. I think with our experience, when a collection occurs, I want to say the average patient bill it's right around $500, $520, somewhere in that time slot, or that amount. Of that amount, I think the hospitals usually will collect about $370 when they use an estimate. So if you look at that compared to where groups are just collecting your standard copay, which again that can range from 25 to, well, let's just say 150 to 200 for hospital copays, that's already $200 to $300 more just by implementing that patient estimate. So and really what that indicates is that communicating, I guess, total patient responsibility, increases that amount collected at the point of service. So having that estimate really is helpful, so you're not just targeting those copays. You can actually effectively collect.
Right. Great. All right, well, we're coming up right on 1 hour, so I think we're going to go ahead and wrap things up. I'd like to thank Collin for the presentation material today, and thank you to everyone who joined today's call. I hope that you're able to take at least something away from today's call. And we have a short survey that will immediately follow the webinar. So if the attendees wouldn't mind filling that out, it's just a quick 5-question survey just to get a gauge on today's session, as we're always looking to improve our material for you. So with that, on behalf of Collin, thank you everyone for attending, and we will see you next time.
Thank you, everyone.